Hey everyone, Justin Jolene here, and I'm excited to share with you this really cool guide on shin splints. So shin splints, as many of you know, are also called medial tibial stress syndrome. And there are so many people that suffer from getting shin splints that unfortunately there's lots they could be doing to avoid these things. Especially people in the athletic population here, and we can see 35% of those folks are getting shin splints, 20% of runners, and a significant amount of military personnel. All those people getting shin splints, they could be avoiding it in the first place. And I want to share with you how people can avoid getting shin splints and what to do if you do have shin splints. But even more than that, shin splints can turn into a bone stress fracture. And bone stress fractures take a long time to resolve, and unfortunately take a lot of time in a boot or non-weight bearing. So how can we help people from not getting shin splints? I'll go through, I'll talk to you about it, and it starts with making sure you're diagnosing them correctly. So shin splints are primarily diagnosed actually through a history and a physical examination. And there's a couple important things that you want to look for, but there's two questions that can really tell you if someone's having shin splints or if potentially they have something else. And that's these first two questions under history here. So the first thing is, does the patient have exercise-induced pain on the distal 2/3 of the medial tibial border? And then secondly, is that pain during or after physical activity, and is it reducing with rest? Those things are going to be really important. If they're saying no to those things, then you're probably dealing with something else, probably not shin splints. And then also you want to rule out. So you're looking for an absence of cramping, burning, and you want to be very, very consistent that they're not having numbness and tingling as well, especially in the posterior compartment. So those are really good things to look for on a history. But what do you do on a physical exam? What should you look for, and what are you trying to recreate, or how are you trying to recreate that pain? Well, very simply, we are going to do some palpation. Palpate the posterior medial tibial border, and they should be having pain or symptoms there. Now, it is also important to note that that's going to be over 5 centimeters, because if they have more focused or focal pain, that's a little more inclusion that they might have that bone stress fracture. So be careful with how far or how much area is covered with that pain. And then also, it's really important here to rule out as well. They're not having any other findings that are not typical to medial tibial stress syndrome. So swelling, arrhythmia, loss of distal pulse. We want to rule out compartment syndrome. So again, this isn't the only conclusion or criteria you should use, but this is a really good place to start when diagnosing shin splints. Let's go over a really cool graphic that I got. And this graphic is actually from E3 Rehab, which is a fantastic reference you can use. So if you go through and take a look at this, this is a really good way. You can just go yes or no. The questions are in the box, and you can just go yes, this person does or has an inclusion criteria for shin splints or does not. So you can go through and use those as a way to be able to diagnose someone with shin splints and use it as a reference. Let's go over risk factors as well, and I broke these down into extrinsic and intrinsic factors. So risk factors can come from things outside of your body or inside your body, and there's a couple interesting risk factors that I want to go over. So extrinsic risk factors, these are very common, especially among runners. Abrupt increases in frequency, volume, intensity of high impact activity. So for those patients that went from the couch to 5K, and maybe they started running that 5K within a week, well, there's a good chance that they're at risk for a shin splint. However, this is not the only thing that can factor into someone gaining a shin splint or potentially leading towards a bone stress fracture. There's also issues of intrinsic factors, and that's going to be high BMI being a big factor, and a couple other really interesting ones. I'll go over that vitamin D deficiency has been debated in the research. There's a little bit of a mix out there. However, vitamin D deficiency has also been related to shin splints and bone stress fractures. But anatomically, and especially when we look at range of motion and we look at strength, those things can be a factor too. So excessive navicular drop can result in some foot pronation and be a risk factor for shin splints. The reason for this is actually because with that pronation, that collapse of the arch, you are then having those muscles that stabilize the arch work a whole bunch more. Well, where those muscles attach is right at that tibial border, that medial tibial border. So that area gets inflamed. You have those muscles working harder, and those muscles then are no longer able to support your body or your body weight. They get overused, they inflame the periosteum, and you see the cascade from there where you're getting some shin splints. So navicular drop is a really, really good thing to monitor. And if someone has a high navicular drop, you also are going to think about their running mileage and be careful that they are not adding too much mileage too quickly. Also, hip external rotation range of motion is another factor to look at. Now, again, the research isn't 100% clear why this hip external range of motion or excessive range of motion here is a factor. What the leading thoughts are is that it causes more mobility in the hip, which could potentially cause a valgus collapse and an overpronation of the lower extremity. However, external rotation is not 100% known why it's a risk factor. But we do see that increased plantar flexion is a significant risk factor for medial tibial stress syndrome, primarily because someone with that increased plantar flexion can not only use those muscles more, but then are oftentimes in a compromised foot position, causing that all those muscles to work harder, again, overuse, causing the inflammation of the periosteum, then resulting in shin splints. So these are your intrinsic and extrinsic risk factors, and we'll get into a little bit more what the risk factors are, but these are important things to evaluate, especially if you're going to have someone to start running, or maybe they're going from an injury to running again. These things are really important to look over. So let's talk running gait deviations that could potentially be a risk factor for shin splints as well. Now, a couple here to look at. Again, we see that overpronation or pronation being a problem, but we also see a couple other issues that are happening here too, and that includes low cadence. It also includes overstriding and narrow gait. So let me start with low cadence as being a reason for shin splints or medial tibial stress syndrome. Now, the reason behind this is because with a low cadence, especially with that really oftentimes coupled with a long step length, you are then going to get more pressure or more impact on the ground because you are having more braking forces. You're oftentimes doing the overstriding with this too. So a low cadence, you're overstriding or putting that foot significantly in front of the center of mass. That's putting the foot out in a position where it's not only causing a lot of impact, but it's also requiring all those dorsiflexion muscles, those muscles that attach to the medial tibia, to be worked really hard. And they're working to then stabilize and act as braking forces for when you're landing on the ground, but it's also going to cause a lot of pain. We do see some relationships here of heel strikers being more risk for shin splints, although that has not been proven in the research. So again, that overstriding, low cadence can all cause a risk factor for shin splint. Also, we see narrow gait being a cause of shin splints as well. Basically, gait that is very close to the center of mass, or it's even crossing over each other when you're running. The reason for this is because oftentimes that narrow gait is going to lead to that pelvic drop, medial collapse or valgus collapse of the knee, and pronation. And all of that is, again, putting more pressure on those arch stabilizers, those muscles that are going to attach on the medial tibia, and again, that is going to cause more pressure. There's also some evidence for some tibial torsion that can happen here too, with tibial torsion being a factor and creating more impact on the bone as well. So let's get into what are some of the evidence-based strengthening corrective exercises you can do. Now, there is some really good framework out there with a couple research articles, and I want to take a second to note that the evidence is really emerging that shin splints are correlated to muscular weakness in the hip abductors and ankle dorsiflexors as well. Now, there's a specific progression that you can go to when you are treating someone with active shin splints. However, it's different if this is preventative. So for shin splints, you'd want to progress strengthening from non-weight bearing to weight bearing to plyometric. And these pictures can be a really good reference and tool to use. So we have our simple resisted ankle dorsiflexion. I like these exercises to be daily. I like them to be at least be done 5-6 times a week. It's a little different if this is preventative. If preventative, the research more supports saying at least 2 to 3 times a week done. However, for people with active shin splints, again, we wanted them to do it every day or as close as they can to every day. Again, with resisted ankle dorsiflexion, we want to get some fatigue in that muscle. Now, the thing is, you might be wondering yourself, well, he's asking a patient to do resisted ankle dorsiflexion. Isn't that something that caused them to get shin splints or an inflammation of the periosteum to begin with? Well, yes, you're so right and you're so correct that this is a factor here. So you'd want to give the patient only as much as they can do. However, we want to push the envelope. We want to give them as much strength as they can early on to be able to strengthen it without causing too much inflammation. Side planks with clamshells are also really good ones to do. This is going to obviously work on those hip abductors. And then as we get into single leg heel raises, again, we are strengthening that arch. We are also strengthening the posterior calf as well, posterior chain as well. Single leg RDLs are a great one to do. Not only does it provide hip stability, it's also going to provide good arch support as well, and it can really get the whole entire lower extremity to be stabilized. Another one that I like is going to be the lunges with rotation on your bottom left corner of the screen. And this one, it can be really effective because it not only provides strength in the lower extremity for the hip, for the quadriceps as well, but it's also going to be a good arch supporting exercise as well. Now, the reason I like the rotation is because that oftentimes makes it so patients want to do some medial collapse of their knee. Well, they have to stabilize the knee. They have to prevent that medial collapse. It's going to strengthen all of those muscles that are going to prevent that medial collapse, especially if that's something they're doing while running or during activity. And then we move into some of the plyometrics. And it's really important here to say we want to build out a lot of these strengthening exercises with weight before we start to introduce plyometrics. Plyometrics can be a great tool, but we want to be careful with adding too much too fast. Single leg forward backwards jumps are great. And while it's not on this list, medial lateral jumping can be great as well. Lateral box jumps and box jumps forward are also good. We can progress from height. We can also progress to single leg as well. All great exercises you can do. Now let's move into some running gait retraining, because not all gait retraining is considered equal when it comes to addressing issues that commonly arise from shin splints. A couple of things that you want to think of. The goals here are going to be to decrease the impact through the lower extremities. So we're going to want to reduce overstriding, excessive step length, and excessive dorsiflexion. We also want to widen the running stance as well, or that base of support, for all the reasons we've already talked about. So what are some of the cues that we do or give patients? Run softly, run quietly, run lightly. There's some really good evidence out there for this. There's also some really, really important ways you can do this. What I do want to take a moment to talk about, though, is telling someone to increase their step rate doesn't always work or isn't quite as effective. So we want to give them these other cues to be able to help them address the reduced or the overstriding, and especially when it comes to really making sure they're not elongating their stride too much. But the way we're going to do that is to tell them to run softly, run quietly, run lightly. We're going to not tell them to increase their step rate as much, because increasing step rate has not been proven in the research to be able to support that they're actually going to reduce that stride length. Also, we want to prevent the crossing over, especially as you're running at a thin white line between your feet. Keep those feet apart. And a great way to track these things is going to be using wearables. IMUs are a great tool to use. You can use Stride, you can use RunScribe, and that can track the lower extremity impact. Running shoes have a little less research behind them when it talks about medial tibial stress syndrome, but there's some commonalities we see, and you can see there's a couple research studies we pulled here. But some of the key points are going to be to avoid minimalist shoes, especially because those are going to be more unstable. It's going to cause you to use your muscles more to stabilize while running instead of using the shoe to support yourself. But you'll also notice I said caution with max support motion control shoes. The reason for that is because with those max support and motion control shoes, they actually cause more impact forces up through the lower extremities because they're doing so much to support it. Think of a orthotic or use of a little arch support. That's going to cause more pressure or impact because it is a higher support. However, again, that rigidity of the max support shoes and the motion control shoes are a little too much for our folks with a medial tibial stress syndrome or shin splint. And then we want to avoid those high cushion shoes because they've proven high cushion shoes create more knee extension, dorsiflexion, and overall more impact or more ground reaction forces through the body. So those are some advice that you can take on shoes. And lastly, how do you get this patient running again after they've had shin splints, or how do you return them to running? Well, a couple key points to look at, and that's going to be when to initiate it. Well, you want to initiate a return to run program after the patient is able to run, is able to be pain-free for 5 consecutive days during ADLs. That's a good measure. However, not only that measure is a good one to go by, we also want to say pain-free during strengthening exercises. We also want them to be able to walk for 30 minutes without pain-free, and they should be scoring over 90% on their LSI during their functional tests. There's a really good article by Warden and another good one by Moen, and they outline a good return to run program. Obviously, there's different return to run programs, but they did one specifically on bone stress injuries, and this can be a really good tool to use for your runners. So again, our phase 1 is going to be being able to walk for 30 minutes, but then we get into walking for 9 minutes and then jogging for 1, repeating that 3 times, and we then progress that to 8 minutes, jogging for 2, 7, jogging for 3, walking for 6, jogging for 4, walking for 4, jogging for 6, walking for 2, jogging for 8. That's all phase 1. Then we get into phase 2. We start to then talk about pace. So jogging for 30 minutes continuously at 60%, and then we're going to then increase that with some rest days, 70%, 80%, 90% full pace. And then on phase 3, we talk about running consecutive days, 30 minutes at full pace, 30 minutes at full pace, take a rest day, 30 minutes at full pace, 30 minutes at full pace, take a rest day. And then we start to add more days in from there. Lastly, here are all the research articles I looked at to create this guide. And there's some really, really cool ones in here that you can take a look at too. I put them all here for your reference. To conclude, medial tibial stress syndrome is very much a preventable thing. There's a lot people can do to avoid medial tibial stress syndrome, especially when it comes to volume, frequency, intensity of running and activity. However, at the end of the day, we want to be careful with these patients. We don't want them to turn into bone stress fractures. And if we can follow our guidelines, if we can be able to make sure these patients are safe and make sure they're in the right shoes, doing the right corrective exercises, and conscientiously and safely returning to running, they can successfully return to running and happily get all their miles in. Good luck with everything, and I'll talk to you soon.